I see there are folks already joining us. My name is Peggy Hasenauer. We are thrilled and honored to welcome you to UChicago Celiac Disease Center Family Education Day. I see participants are already joining us and the numbers are going up. That's fantastic. So welcome. Welcome Becky and Bruce and Debbie and Janelle. Welcome John and Lisa and Maria. Omar and Sally, thank you so much for being here. Wayne and Trish and Samuel, we're just so happy that you're joining us this morning. We have many people joining us, not just from the Chicago area, but from throughout the US. And we have a fantastic lineup of speakers today. We want this to be fun and interactive for you and your loved ones at home. And we encourage you to ask questions. Sean has now joined us, and Nia and Michelle. Margaret and Madeline, hello, thanks so much for being here. Dr. Amy has joined us. Cynthia, thanks for being here. Numbers are going up and up and up. I love seeing that when people are joining us. That's great. We have some fantastic panelists today and speakers. We'll talk a little bit about what the day is going to look like. As I mentioned just a minute ago, my name is Peggy Hasenauer. I'm a nurse and I'm also the interim director of the Celiac Center at the University of Chicago. We've hosted many events. Most are in person, but with COVID and all the changes that we've made in our culture and in our world, we are doing this one virtually today. So a different format for families, but please bring your loved ones to the computer with coffee in hand or breakfast and join us. We will have some opportunities for Q&A, a few questions at the end of each presentation, and then we will have a fantastic panel discussion. So Judy's here and Katya, thanks for being here. We have many Jennifers and a Jenny and a Jared. Thanks for being here. Hi, Gina. Hi, Andrew. Thanks for coming today. Please feel free to encourage family members to join us as well, or to just pop in for one of the presentations that look interesting. It's about 8:32, and so I think that we are going to formally get started. So as I mentioned, I'm Peggy Hasenauer. I'm a nurse. I'm also the executive director of the Kovler Diabetes Center, and for the last 18 months I've had the privilege of acting as interim director of the Celiac Center at the University of Chicago. We are honored and grateful to have you here today for our first virtual Celiac Center Family Education Day. We have a fantastic lineup of speakers. I wanted to share with you that we will have tech support throughout this event, and I think that's important to note. So if you have any concerns or questions, in the chat function, you'll see the chat button at the bottom of your screen. You can click on that and there will be information from our colleagues who are running this meeting today, and they will share more about tech support. I also wanted to make sure that those of you who have questions, your questions can be asked by utilizing the Q&A button. So not the chat button, but the Q&A button at the bottom of your screen. We're trying to separate chat from Q&A today. So the Q&A button can be utilized to ask questions, and we will try to do so at the end of each speaker's presentations, but we will certainly focus on those for the panel discussion. If you have questions about our programs or services, or you'd like to learn more, or you'd like to understand how you might get copies of slides or a recording, or if you need an appointment, even a virtual appointment, we want you to contact my colleague, Karen Wu. Karen will provide her email information in the chat, and you are welcome offline via email to ask specific questions about setting up appointments or anything else that you need. I also wanted to make sure that you know that we have so many people to thank for putting this event together. We have a fantastic celiac council made up of passionate individuals who support our programs and services and advocate for us, so thank you. I also want to thank Karen, my trusted colleague and partner, for putting this event together. And of course, Meeting Achievements. Meeting Achievements is a company that we've been working with on virtual events like this, and we're very grateful to have them help us today. I wanted to also let you know that we will have a break between 10:10 and 10:40 a.m. So that, of course, depends on how we're doing time-wise this morning. But what we'd like to do is from 10:10 to 10:30, we'd like to let folks stay on if they want. We can provide audio if you'd like to ask a live question. You can also put questions in the Q&A. We can also just sort of like chat informally, but we have to do so one at a time. So let us know in the chat function or in the Q&A function during that time from 10:10 to 10:30. If you can't join us for this entire event today, know that this entire program will be recorded and that you will be able to access it through a link that we can provide to you. We can also have it on our website so that you have access to all of the presentations. I think that's so important as part of registration for you to be able to share this with other family members or friends or colleagues or teachers who perhaps could not join us today. So just know you'll get all of the presentations, and we are just thrilled to be able to provide that for you. So let's go ahead and get started. I can't thank you enough as the attendee lists go up and up and up. Thanks to everyone for joining us today. We have a fantastic speaker. Our first speaker is Dr. Ritu Verma. Dr. Verma is a professor of pediatrics at the University of Chicago. She is the section chief of pediatric gastroenterology. She's the director of the Celiac Center. She came to us a couple of years ago from the Children's Hospital of Philadelphia, where she has created really a national movement and a national presence in understanding celiac disease and taking care of children who really need us the most in their care and education. Dr. Verma is going to speak to us today and give us an update on gluten-related disorders. And it's just been an honor and a privilege to work with you all these months, Dr. Verma. So thank you so much, and take it away.
Good morning. Thank you, Peggy. Thank you, everyone, for joining us this morning on a Sunday. I really appreciate everyone's presence here. So I'm going to share my screen. Hopefully, we'll be sharing a screen. Okay, so the objectives for today's talk really is to talk about gluten-related disorders, but really talk a little bit more about celiac disease as well. I'm having a little trouble forwarding the slides, so I'm just going to need some tech support.
If you try to click them, there you go, Dr. Verma.
Okay, thank you.
Yeah.
When we did the trials earlier in the day, it all worked, but of course, as you get started. So as Peggy said, let everyone sit down with your breakfast, have a cup of coffee. Let's try and make it a sort of relaxed discussion. You know, what happens is when I'm seeing patients, there's always so much questions about what is there besides celiac disease? And I eat gluten and I have a problem. And what is gluten? So gluten, of course, is wheat, rye, and barley. But there's more to that than celiac disease. And we thought that maybe we'll give a little overview about other disorders besides celiac disease that also get manifested if you eat gluten. And the majority of ones that we all know commonly is about celiac disease. And then we have wheat allergy, and then there's gluten sensitivity. So lots of names, lots of words, lots of confusion, and hopefully we'll be able to sort out some of the confusion. We give a broad category of saying that how do people get gluten-related disorders? And there is the immune-based, the autoimmune, that's celiac disease. There's the allergic phenomenon, that is wheat allergy. And then there's gluten sensitivity, where people sometimes confuse gluten sensitivity with celiac disease as well. But as we go through the talk, we'll see that gluten sensitivity is very different than celiac disease. Part of the confusion arises is because With certain diseases, the symptoms are all the same, but we have biomarkers that are available for certain conditions. So we have biomarkers for celiac disease, we have biomarkers for wheat allergy, but unfortunately, currently, we do not have biomarkers for gluten sensitivity. So the next 20 minutes or so, or 25 minutes, we'll talk a little bit more about wheat allergy, gluten sensitivity, and then finally land at celiac disease. So what is wheat allergy? It is probably the most common grain allergy, and 4 out of every 1,000 children in the United States have a wheat allergy. And usually these children will outgrow this allergy by the time they're 5, unless they have a lot of allergies or eczema, then it might take much longer for them to outgrow this allergy. In adults, usually they don't have a wheat allergy per se, but they could have other conditions that manifest with the symptoms. And there's something which is commonly known as Baker's asthma. And as I learned, I'm not an allergist, I'm a gastroenterologist. As I learned, Baker's asthma is often seen in bakers who are exposed to wheat. It could be to other grains as well, but since we're talking about gluten, we'll keep it to wheat. And they have typical symptoms of asthma. And the treatment is, of course, don't be around wheat, but also treat the asthma. So in allergies, you have an immediate reaction and a delayed reaction. I think most of us know the immediate one. The most famous or notorious one is a peanut allergy. So anyone who has a peanut allergy knows if they are exposed to peanuts, within few seconds, within few minutes, up to 2 hours after you eat that particular food, and in this case, wheat, you'll get typical allergy symptoms, which are the hives, the swelling, the breathing issues, and there are GI symptoms associated with that as well, including vomiting and diarrhea. The diagnosis for this is made by an allergist. It's made given the history and, of course, skin prick testing. No endoscopies, no other testing is really needed to make this diagnosis. And then we do have wheat allergy where there's a delayed reaction, which is not related to IgE, which is more the immunoglobulin. This occurs more slowly, so children may eat the wheat, may not have a reaction for even a couple hours, and then they have symptoms which are predominantly GI. So you'd have diarrhea, bloating, gas, sometimes difficulties in swallowing. And this can be a reaction that can occur way beyond 2 hours. You could eat wheat today and have a reaction several hours later. And the diagnosis here is quite difficult. The history is important. Sometimes you can have some blood tests done, but really the allergists find that there's no skin or blood tests that are recommended or helpful for delayed wheat allergy. However, think about it, the symptoms are the same as you would have if you have celiac disease. People would say, well, maybe I should do an endoscopy to make a diagnosis. In some of these cases, there's one condition which is called eosinophilic esophagitis, where you have inflammation or irritation in your food pipe on the basis of food allergies. That diagnosis is made on an endoscopy. But truly, with the delayed wheat allergy, there's no blood test or skin test that can be done. But both of these conditions are treated with dietary restrictions. So again, it comes under the gluten-related disorders. And then, of course, the most famous or notorious besides celiac disease is non-celiac gluten sensitivity, and often gets confused with celiac disease. So the symptoms predominantly that children have with non-celiac gluten sensitivity, or adults, almost 70% of children and adults with non-celiac gluten sensitivity will complain of abdominal pain. And as we go through the list, you can have rashes, headaches, foggy mind, fatigue, diarrhea. So very similar symptoms to celiac disease. These are the predominant symptoms that are seen. So what happens to children with or adults with non-celiac gluten sensitivity? We really don't know exactly why people get non-celiac gluten sensitivity, but the thought is that if in the individuals who have this condition, every time they eat gluten, it causes an immune reaction that occurs on the lining of the small intestine, or it could be that there's a change in the gut microbiome. And so whenever there's gluten that's in the gut, it changes the gut microbiome, and it starts off this whole cascade of non-celiac gluten sensitivity and gives you all the symptoms that you see that are both GI and non-GI symptoms. So you can have both GI and non-GI symptoms with non-celiac gluten sensitivity as well. There really is no genetic basis that has been found yet for this condition. So then the confusion is, how do I really diagnose this condition? You know, from a patient standpoint, I eat gluten, I get symptoms of diarrhea, rash, and so on. How do I know whether it's non-celiac gluten sensitivity or celiac disease? Not that easy to start off. Unfortunately, you have to be eating gluten to know whether you have any of these conditions. There are no specific blood tests for non-celiac gluten sensitivity. As we'll go through the talk, my talk today, and also Dr. Jericho's talk, we'll hear about the blood tests that can be done for celiac disease. But for non-celiac gluten sensitivity, there is no specific blood test. There are some studies done that you look at and they talk about maybe in some people you would have gliadin antibodies that are elevated, but controversial. The usual celiac antibodies, the testing for wheat allergy is negative to be able to diagnose NCGS. If you do an endoscopy while the person is eating gluten, often in non-celiac gluten sensitivity, the biopsies from your food pipe, stomach, and small intestine are normal. So it's important that none of the celiac antibodies are abnormal, no test for wheat allergy is abnormal, and the endoscopy is predominantly normal. So here we go again. How do I make a diagnosis? Well, first of all, write down the symptoms that you have while you're eating gluten. Very important to be very organized and systematic about this. So write down the symptoms that you have while you're eating gluten. And then you've got to take gluten out of your diet for at least 6 weeks and reevaluate the symptoms. So all the symptoms that you had while you were eating gluten, you reevaluate them. If all the symptoms are gone, then most likely you have non-celiac gluten sensitivity, but we still have to prove it. However, if the symptoms are still present, then of course your symptoms are not because of gluten. So please, please do not just stay and say, well, maybe I had some gluten in my diet and that's why I have symptoms. If for 6 weeks you followed a gluten-free diet and the symptoms are persistent, follow up with your medical practitioner to see what else is going on. On the other hand, if there's total resolution, then to know, is it gluten that's the problem? You have to re-challenge with gluten. And I often say when you're re-challenging with gluten, then give pure gluten. If you eat bread and you eat pasta and you eat 10 other things that have other ingredients in there and you start having symptoms, it's kind of hard to know, was it wheat, rye, or barley that caused the symptom, or was it something else like fructans? So very important to get this diagnosis established. Of course, the treatment for non-celiac gluten sensitivity is a gluten-free diet. It does help to resolve symptoms. But the most important thing to remember there as well is that you don't have to be as strict with a gluten-free diet if you have non-celiac gluten sensitivity as you would in celiac. This condition is not associated with severe malabsorption, not associated with increased risk of malignancy. There are some studies that show that there is a high prevalence of some thyroid disease in individuals with non-celiac gluten sensitivity. So once again, I urge everyone to actually get a diagnosis made before going on a gluten-free diet. Make a diagnosis, is it celiac, is it allergy, or is it non-celiac gluten sensitivity? So let's talk a little bit about celiac disease. And please don't forget your questions in the chat. So celiac disease is an autoimmune condition, and the prevalence is about 1%, and it's growing. It occurs in genetically susceptible individuals. And of course, it's a unique autoimmune disorder where we know what causes it. We know the symptom, we know the trigger, it's gluten. We know that we can test for it with the antibodies. And we know that if we take off the trigger, that's gluten, your symptoms improve, your biopsies improve, your blood tests improve. We also know that it's a permanent sensitivity to gluten. So different than non-celiac gluten sensitivity. It's present in 1 in 100 to 1 in 80 children. Females tend to be affected more than males, but we do know that it affects all age groups. So you could be 2-year-old and have celiac disease, and you can be 60-year-old and have celiac disease. The risk of celiac disease is definitely much higher with siblings, first-degree relatives, and also 5 to 10% of children with type 1 diabetes end up with celiac disease. There is something called selective IgA deficiency, and 5% of people who have immunoglobulin A deficiency also end up with celiac disease. One of the most important things to remember also is that it can be seen in any ethnic background. You do not have to be from Ireland to have celiac disease. You really could be from any part of the world. And why is it important? Why do we really care about celiac disease? If it's untreated, it does pose long-term adverse health consequences, multiple of them, poor growth, neurological complications. But to me, the most important thing is there's an increased risk of autoimmune conditions. That to me is the most important reason why you want to know whether you have celiac disease and to be managed early. It's also really important that the diagnosis be made as early as possible in children. We do know that if a diagnosis is made beyond 10 years of age, almost 25% of those children will end up with another autoimmune disease. So early diagnosis, early thinking about celiac disease, getting the blood test, really important before you go on a gluten-free diet. The pathogenesis, we all know that to have celiac disease, you have to eat gluten. There's a genetic to it. There's a risk factors. For today's talk, I'm only going to talk briefly about some of the risk factors. There are lots, people may have heard, oh, the risk factor must be because I was on Prevacid or I was on Nexium or some acid medication. Really, none of that has been proven totally. But I do want to mention a little bit about the patterns of feeding for babies. So what has been found, and this has gone over many years, so some of you may have heard different, but current theories, it does not really matter when you introduce gluten to the newborn. It does not matter whether you introduce gluten at 4 months or 6 months or 12 months. It did not seem to have any effect on the risk of developing celiac disease at 3 and 5 years. The duration of breastfeeding or continuing breastfeeding at the time of gluten introduction did not have any influence either. The type of gluten, whether it was solid or cereal in the formula, did not affect the celiac disease risk. Maternal diet during pregnancy and lactation does not affect the risk of development of celiac disease. What we do know though, of course, if a mom has celiac disease, she should be on a gluten-free diet. What we have found recently, at least for now, and as you know, science keeps changing, the amount of gluten in the first 5 years of life is associated with an increased risk in high-risk families. So what does that mean? That means that if you have a child and you have celiac disease and you have a child, moderating the amount of gluten in the first 5 years of life is important. If you're doing an excessive amount of gluten in a high-risk family, it puts you at a higher risk to develop the disease. We also believe that altering the microbiome, early life infections can all be triggers as well. In this slide, I just want to mention a little bit about the genetics. So there are 2 HLA types that are associated with celiac disease. In order for someone to have celiac disease, you have to have the DQ2 or DQ8. More than 90% of patients with celiac disease will have the DQ2, and then some will have DQ8 as well. Just because you have these particular genes does not mean that you have celiac disease. It just means that you have a predisposition. There are many people who have these genes that do not ever develop celiac disease. What we do know that if you are negative for DQ2 or DQ8, it's very unlikely that you will have or will develop celiac disease. What we also know that if you have 2 copies of that DQ2, you're at a higher risk to develop celiac disease. So what has been found in studies is that you have 2 copies of the DQ2, you have a much, much higher risk of early development of celiac disease. If you're a girl and you have 2 copies in a high-risk family, higher chances of developing celiac disease. If you're a girl, double copy DQ2 in a high-risk family, you probably will end up with celiac disease diagnosed much earlier in life than later in life. So again, a significant risk factor. So now I'm going to go on to what are the clinical symptoms with celiac disease. We talked about wheat allergy, we talked about non-celiac gluten sensitivity, and here's celiac disease. So look familiar, right? So All the other conditions we talked about that are gluten related also cause vomiting, they also cause diarrhea, and these are the things that we get with celiac disease as well. The younger the child, the more symptoms like vomiting, not growing well. The older the child, you probably get more symptoms with things like headaches, iron deficiency, anemia, short stature, and so on. So bone disease and celiac disease can present in many different ways. You can have joint pains, you could have low bone density, higher risk for fractures, and it's probably related to some extent on an autoimmune basis. And to some extent, it's related to malabsorption and you're not absorbing the calcium. Sometimes people with celiac disease will have a lactose intolerance, so therefore they're not getting in as much calcium as well. So all predisposes you to bone disease. Neurological symptoms, which are in the past, often people would say that celiac disease does not have neurological symptoms. We do know that up to 25% of patients with celiac disease on a gluten-free diet could have a peripheral neuropathy, meaning more like affecting their hands and fingers and having tingling sensations and so on. Seizures, as 4 to 8% of people with epilepsy have celiac disease. And there have been found certain specific head MRI changes in people who have celiac disease. There's a brain white matter differentiation. One of the things, I'm just going to go back here, but we'll continue with gluten ataxia. So again, a condition which is autoimmune based, gluten related, seen in almost 15 to 40% of people with gluten ataxia that it's related to gluten. Unfortunately or fortunately, less than 10% of children with gluten ataxia have GI symptoms. So what happens is you often land with a neurologist, and if the neurologist is not thinking gluten, it could be a tough diagnosis to make. Even if there are no GI symptoms, and celiac panel, upper endoscopies should all be done. And 1/3 of people with gluten ataxia that's related to gluten may have biopsy changes. However, the brain imaging, the MRI, is extremely important. And this disability lasts for a long period of time. A gluten-free diet alone is not helpful. There are many supplements that are needed, but the gluten-free diet is one of the therapies for gluten ataxia. An important thing to remember, an important thing to educate our neurologists with. There are many behavioral issues that are related with celiac disease. And as you can see, that learning disabilities, anxiety and depression, sometimes anxiety and depression happens after, as we put the limitations on the diet. One of the things that we're doing in our celiac center here is starting off a study that will be looking at brain fog and celiac disease and looking at it from a mechanistic standpoint of why people get brain fog, how do we manage it, and we'll be working with our psychologists and also going on with MRIs, but it's a study that will be starting very soon. This is the rash that's seen with celiac disease. Extremely itchy, extremely painful. The diagnosis for this can be made on a biopsy of the rash. So the dermatologist, the skin doctor, needs to be in tune with actually doing the stains, looking for that. Getting the blood test for celiac disease is important. Going on a gluten-free diet is part of the treatment. We do find in children, and again, I'm a pediatric gastroenterologist, so of course, growth is really important in our practice. So almost 10% of children who are not growing well have evidence of celiac disease. And if we can catch it before puberty sets in, they actually can have the total growth that they were going to have, they were destined to have genetically. So once again, very important to get early diagnosis made for our children. These are the dental enamel defects that can also be seen in children. There are many blood test abnormalities. You get a low iron, liver enzymes can be elevated, there are vitamin deficiencies, lots of different blood test abnormalities that can be seen. So anyone who's being worked up for anything related with gluten really should have a comprehensive workup done to really make a proper diagnosis. We all talk about malignancies and complications with celiac disease. I just want to pause here for a second, that if you're adhering to a gluten-free diet, if your diagnosis is made on time and you're adhering to a gluten-free diet, the risks go down. It's when we are not diagnosed on time, we're not sticking to the diet, that's when you have increased risk of all these malignancies and the complications. So very important to keep that in mind. So who should be tested for celiac disease? And I'm sure there's some people in the audience who know me very well. And in my mind, everyone should be tested. The symptoms are so diffuse. So therefore, you have chronic headaches, you should be tested. You have joint pains, you should be tested. So in my mind, every time the child gets all children get lead testing or used to get lead testing, they should get a celiac panel done. But that's my bias. So who should really be tested? The relatives, patients with short stature, any of the associated diseases that we talked about earlier. And how's the diagnosis made? Dr. Jericho will talk about the diagnosis, but please remember, do not start a gluten-free diet prior to the complete workup that's been done on whether you have celiac, you have an allergy, you have non-celiac gluten-related disorder. It is going to be big implications down the line. So do not start a gluten-free diet till your workup has been done. And what's the treatment for celiac disease? It's a lifelong commitment. So for now, at least, we'll talk more about in our second session. Dr. Leon will talk about other things that we have as part of treatment for celiac disease. But right now, it's a lifelong commitment to stay on a gluten-free diet and to avoid cross-contamination. We do know that even a small amount, even just about 50 milligrams, is enough to cause mucosal damage. So to wrap up, the gluten-related disorders really need to be managed appropriately. You should not just go on a diet. Who are all needed? We need the pediatricians, we need the gastroenterologist, psychologist, dietitian. Don't go on this journey alone. Join us and we will help you manage these gluten-related disorders. Long-term implications, very different. And I'm going to sign off before Peggy throws me off. So thank you. Thank you very much, and we'll be around to answer any questions. Hopefully, I have not alarmed anyone, but really, really, really want everyone to please don't start a gluten-free diet till you know what your child has or till you know what you have. And that's all I would have to say. Thank you.
Thank you, Dr. Verma. I'm so grateful that you kicked us off today with some really nice information. Dr. Verma, we do have a few questions that have come in. So I would like to ask those and then have you answer them. First, in no particular order, what if the symptoms of celiac disease are present when a person is on a very strict gluten-free diet? Are there other disorders that can be tested for?
It's an excellent question. Really, one should not blame those symptoms on a gluten-free or on celiac disease. So if you have celiac disease and you're on a strict gluten-free diet, the first thing, go meet with your dietitian, go meet with your practitioner, make sure that there's no little hidden things coming along. Unfortunately, there are products that have been labeled gluten-free and then the same product comes back on the market and has some gluten in it. So sit down with your team. Sit with your dietitian, sit down with your physician, go through the diet, go through everything. If you truly are 100% gluten-free, other things can give you the same symptoms. So bacterial overgrowth, irritable bowel syndrome, other food allergies, intolerances, so multiple things. Do not ignore those symptoms. Don't go crazy saying, oh my God, I must be eating something. Sit down with your team. That's what we are here. We are here to work as a team. This is a family, so family, the physicians, the nurses, the dietitians, join us, let's do it together. But many other conditions will give you the same symptoms as well.
Great. We have another fantastic question. If you have had blood tests confirming celiac disease, that does not negate the possibility of NCGS, or do you need more testing to confirm celiac? I guess I'm not sure if I understand the question, but I hope you do.
So I'm going to say the question back and see if it's the right question. So I'm guessing that you're asking if my blood test is abnormal for celiac disease. If the blood test is abnormal for celiac disease, you don't have to worry about non-celiac gluten sensitivity because you're going to go on a gluten-free diet.
Right.
If the question was, my blood test is normal, do I have NCGS because I have symptoms? If that's the question, if your blood test is normal, the first thing we want to find out is how much gluten were you eating? One of the pitfalls of getting a blood test done and it being normal is that you may not be eating enough gluten. So if you're not eating enough gluten, your blood test for celiac disease is not going to be abnormal. So we don't want to go down the journey of NCGS till you've totally got that answer. So if I have a lot of gluten in my diet and my blood test is normal, then you can go down the journey of looking at NCGS.
But if you have a diagnosis of celiac that's confirmed, you don't really have to worry about NCGS, especially if you're on a gluten-free diet.
Absolutely right, Peggy. So
Okay.
you should be doing that exactly.
Great. A few other questions. Can celiac or NCGS develop as an adult at age 45?
Yes, absolutely. Absolutely. Any age, any age. And it doesn't mean that your physicians, well, sometimes yes, sometimes no, but it does not mean that you've had celiac disease for 45 years. You can start the whole process. The immune reaction can happen at 45. So it could totally be that you had the genetics for it, and then whatever the risk factor occurred at 45, and then you ended up with celiac. But yes, you can have at any time.
Great. So a good question about the COVID vaccination being gluten-free and safe for those with celiac. Our understanding is that it absolutely is. I actually confirmed this question with one of our team members this week. Dr. Verma, can you share a little more?
Absolutely. Everyone, there is no problem getting the vaccine. And also just to reassure people, there is no high risk of getting COVID infection if you have celiac disease. We have a national, international registry going on, and any physician, any provider who has a patient with celiac disease, if they have any COVID infections, we have a database, a registry, and there really has not been found to be any increased risk of getting the infection if you have celiac disease. Or if you with that. And what I always tell the families that I see, the children with celiac disease are really well equipped to manage with the COVID, because we tell our children, wash your hands before you eat, wash your hands, don't share your food. This is what we're telling everyone who have, with social distancing and so on. So in my mind, the children with celiac disease were well prepared for this pandemic. So no increased risk.
Great. I have a question that I might be able to answer myself. How do I find a quality gastroenterologist who will treat celiac disease in adults in my community? I have a son who's aging out of his pediatric GI physician and needs an adult practitioner. So it seems that there's difficulty in finding GI docs that focus on celiac disease. And so what are the recommendations? So I suppose I could answer this, that we have a combined celiac center that incorporates kids and adults. We also are developing a transition program for younger children who are getting older and don't want to be seen by a pediatrician anymore. We can also see families virtually. Doesn't matter where you live in the United States. It just depends perhaps on insurance and coverage. So my recommendation to the person who asked this question is, we're here to help. We can certainly set up a virtual appointment. We have some of the best experts in the country focusing on celiac disease. So for your son who's aging out of his pediatric GI physician, get in touch with Karen. She'll put her information again in the chat and send her an email, and I can personally help you. One other question. I'm just taking a look at time here. It's 9:07. We are doing well. Dr. Michelle Asimov is asking a question about perhaps a different topic, and it's regarding lymphocytic colitis and your experience with treatment. So not necessarily celiac related, but certainly GI related.
So with celiac disease, there are patients that have, if you do a colonoscopy, you'll actually see some inflammation in the colon, which is related to lymphocytic colitis. So there are some children that get better just on a gluten-free diet, and then there are others who need to be on medications. So if someone wants to go offline and send a message to Karen, I can help them with that. But there are medications that can be used for lymphocytic colitis as part of treatment. So different, but you still have to stay on a gluten-free diet.
Yeah.
That would be helpful. There are medications that can be used to help.
And doctor, feel free to reach out to Karen via email, and we are happy to consult and answer more questions regarding treatment options for your patients. So this is an interesting question. This is more technical perhaps, but my 14-year-old daughter was diagnosed with celiac 5 years ago. Most of the markers in her blood work have returned to normal levels since starting a very strict gluten-free diet. But some of her levels, her IgG remains greater than 250 units per ml. So could this mean that she remains at increased risk even with a gluten-free diet? Is there something else we should be doing to consider regarding her health?
So it depends on which IgG we're talking about. I know Dr. Jericho will be talking more about the serology and the blood tests.
Yes.
But I do think that it's very important for the person who's asked this question for us to know which IgG is elevated. So there are different IgGs. So if it's just the total immunoglobulin IgG that's elevated, then not to worry. But if it's a celiac IgG, then we would just need to know a little bit more information before I can give you a correct answer.
Sure, and it looks like she did list some information here, but I think what we'd like to do, Becky, who asked this question, we are happy to answer more questions via email or by phone, and we certainly can also set up a virtual visit for your 14-year-old daughter. We're happy to do it. So reach out to Karen via email, and we will get in touch with you. So this is interesting. Does intermittent...
Peggy, if I can just jump in, just looking at that, if it's the deamidated IgG that's elevated, please do make an appointment or a discussion should happen.
Great, great. Thank you for that. This is a good question, and I think we're going to end on this. I think a lot of folks do their best to stay on a gluten-free diet, as you know. But Samuel asked a good question. Does intermittent or unintentional gluten exposure increase the risk of any complications? And this is really hard for people when they feel like they've made an error or accidentally they feel like they were exposed. The anxiety related to this is something we're going to talk a little bit more about and on this in future events. But can you speak to that? And can you talk about like the actual risk of long-term damage or complications if people have an unintentional gluten exposure?
You know, there's the practical answer and then there's going to be the scientific answer. So I'll give you the practical answer. If you get exposed accidentally to gluten today, and it's once in a year or so, in my opinion, it is not something that's going to set you back. It depends, of course, on how often you get these accidentals. So the thing is that if you do get an accidental exposure, the first thing you want to learn from that exposure is so that it doesn't happen again. What we don't know is if you have one accidental exposure a month, what happens? You know, just think about how we would never be able to study that. So the frequency is important. If you get accidental exposures every week, which would be something's got to be different, it's no longer accidental, then perhaps you're at an increased risk. But once a year, there's an accidental exposure that happens, in my opinion, no. From a scientific standpoint, we don't have those studies to show. We do know that if you get exposed every day, that yes, there'll be damage to your intestine. But accidental now and then, try and learn from that experience. Don't keep on getting accidental exposures. Peggy, you're on mute.
Maybe people want to mute me more often. What I'd like to do is answer a few other questions. I'm going to type in some answers, and we're also going to encourage you, especially if you have questions about a child. There's been some really great questions about your own children and also your own care. So please feel free to email us. We will do the best we can to answer your questions via email, but if it's anything like really clinical, we prefer to set up a virtual appointment with you. Even if it's a one-time virtual appointment, even if you have a GI physician that you're very happy with, or a primary care doc you love, or you're on a gluten-free diet, there is no harm. I said this many times that never in this time in our lives have we been able to get a second opinion from the comfort of our own home with our pajamas on. So if you want to set up a virtual appointment with the world's best experts, you can, and that's a blessing. So please feel free to reach out to us and we'll do all we can. Dr. Verma, it's been a pleasure. Thank you so much. I know you'll be joining us later today, so thank you.
Thank you.
I wanted to move on to our next speaker, Dr. Hillary Jericho. Dr. Jericho, it's great to see you. We are honored and privileged to have you speak with us today. Dr. Jericho is a gastroenterologist with the Department of Pediatrics at the University of Chicago, Comer Children's Hospital, and Celiac Center. She's going to be speaking with us today on diagnostics and celiac disease, which is very timely. We've had some fantastic questions about genetic testing, about biopsy, and about blood tests. So Dr. Jericho, thank you. Take it away.
All right, thank you, Peggy, and thank you, Dr. Verma. I will kind of pick up from where they left off. Let me just share my screen and then pull up the presentation. Give me 1 second. All right, and let me just check, Peggy, did that come through correctly?
Yes, it looks good.
Okay, perfect, just double checking. All right, thank you. Okay, so like I said, I'm going to speak on the diagnostics of celiac disease today. I just want to say the first slides that I'm talking about regarding blood testing and endoscopy are kind of the more standard approach. After that, I'm going to be talking about some imaging and some other techniques, such as something called a capsule endoscopy, which really is not standard of care. So I don't want you to leave this and go back to your physician and say, why didn't I get that? It's more kind of in the research mode, and people are looking at it as a modality that may be helpful in the diagnosis of celiac disease. But as it stands, it's not standard of care. So I just want to put that out there before I get to those slides. All right, so the learning objectives of this talk are to discuss the current testing for the diagnosis of celiac disease, and also afterwards to quickly discuss the current testing for the detection of accidental gluten exposure. I know there have been some questions about that. So how to evaluate for celiac disease? So typically you have a patient, you'd have a reason for it. One, either the patient's having either typical or atypical symptoms of celiac disease, such as gastrointestinal, or other things like Dr. Verma had talked about, symptoms outside the GI tract that may be suggestive of celiac disease. We also have those asymptomatic patients that would be high risk. They have other family members or have other disease entities that, again, are more highly linked with celiac disease that may prompt us to want to test for that. Next, we typically, the first line testing is to get some blood antibodies to see if they are suggestive of celiac disease. And finally, if they are, and both of those things go together, the patient's symptomatic or have a high risk disease or family member exposure, and the blood testing is positive, typically that last step, which is the gold standard for the diagnosis of celiac disease, is to move forward with that upper endoscopy, grab those biopsy specimens, look at them under the microscope, and see if they confirm the findings that would diagnose celiac disease. All right, so I think my patient may have celiac disease. We'll start with the blood testing. So these are the typical blood screening tests that we may get. Most of you have probably heard of the first one. It's called the tissue transglutaminase IgA. For most individuals, that is going to be the first and foremost screening test. It's very good. It's got very high levels of sensitivity and specificity, and it's a fairly cheap test in the greater scheme of things to get. In case you are not aware what specificity and sensitivity mean, and I always forget despite all of my background training, I will tell you quickly if you see those numbers what it would mean. So the sensitivity of a test is related to the disease. So what that means is if you have a disease, how often is that test going to accurately reflect that? And so depending on the studies that you've looked at, the sensitivity of that TTG IgA is 90 to 98%, which means if you have celiac disease, 90 to 98% of the time, that test is going to accurately reflect that and come back positive. What does the specificity mean? That means if you don't have celiac disease, how often is that test accurately going to show that you do not have celiac disease? And that sensitivity, it's similar. It's about 94 to 97%, again, looking at what study you look at, meaning if you don't have celiac disease, that test should come back negative. As you see, neither of these are 100%. So there are always those exceptions that the patient is going to have celiac disease and the test is not going to detect it, or that patient doesn't have celiac disease and the test comes back positive. And that, again, is oftentimes the reason we really want to do that scope and we want to get biopsy confirmation, because as you know, this is a lifelong condition and we want to get it right. We don't want to put someone on a diet for the rest of their life when they don't have the disease. The TTG of all of these, I would say not more often than not, but more frequently with this test, we may get mild false positives. There are other disease entities, and I'm not going to go into them in great detail, that can cause false positives or cross-reactivities of antibodies from other autoimmune conditions that can cause this to be falsely positive. And again, that's why we always want to do the scope, get the biopsies, and really know that what we're dealing with is celiac disease. The second antibody, and this may have been the one being referred to in the question below, and of that TTG, we also do have a TTG IgG test that we can get. That one is not as good as the TTG IgA. For the most part, we don't often send that unless someone is what we call IgA deficient, and I will go into that in 1 second as well. In that situation, the patient, their IgA levels are not going to be accurately reflected, so we get the IgG as well. The deamidated gluten peptide IgG is another antibody. It's a newer antibody that we can look at. It's thought to not be as good of a reflector of active celiac disease in adults, but we do find it that it can be a more accurate reflector of celiac disease in children, especially those under 3 years of age. So we will often send that in conjunction with the TTG in the younger children, or again, if a patient is IgA deficient, we will get this one because it is a IgG-based test. The third test on this lineup, it's called an endomysial IgA. This is really thought to be the best antibody test that you can send for celiac disease. But the difference between this one and the other two is that this one actually requires a person to process the test, look at the results, and then reflect on how positive they are. So it can be subjective. The problem with this test, sometimes if it's done at centers that don't have the expertise to run this test, it may not be reported out accurately. So with the endomysial IgA, because it is more expensive because it's run by a person, it's not our first line test. But if there's any uncertainty, or again, you want another test to back up the thought that this patient does have celiac disease, the endomysial IgA is a very, very good test to get as a second run test to support your hunch in a certain subset of patients, which I'm not going to get into. If the TTG is high enough and you get this test and it's positive too, that again puts a lot of weight on the likelihood that that patient is going to have celiac disease. The very last test here is called an anti-Gluten antibody. It is the oldest antibody test that we have. It's one of the first antibody tests that was ever discovered. But as you can see down below on this one in particular, the sensitivity and specificity are much lower than any of the other antibody tests. For that reason, because it so often can be falsely positive or falsely negative, we really do not send this test anymore. Most centers, you can't even order it. But this was, I put it up there just so you are aware of all the testing. This was one of the first antibody tests that we get. As I mentioned before, in addition to these celiac specific antibodies, we will always get what's called a total immunoglobulin A level. All of us have immunoglobulins in our body, different letters. So there's an IgA, there's an IgG, there's an IgM. They all signify different parts of the immune system that do different things. The IgA is specific to our gut. And in order to get a positive test for one of these tests, you have to be producing adequate amounts of IgA. So about 3 to 4% of patients with celiac disease may have what we call IgA deficiency. So they just don't produce enough IgA. At the end of the day, most of the time, this isn't going to cause anything harmful or bad. They just have lower levels. So when we get the IgA test, the reason we get that is just to ensure that person's producing enough IgA, that the results of these tests that depend on it, like the tissue transglutaminase IgA or the endomysial IgA, we know is going to be accurate, that that person produces enough IgA that they can produce enough to show us that they have a positive test. Question I get a lot is, oh, my IgA was flagged that it was high. Is this a bad thing? Does this mean I have celiac? Not at all. A high total IgA is not anything harmful or bad. And really the reason we get it is to make sure it's not too low. If it's high, you've got a good, robust immune system, nothing concerning, and we know we'll get an accurate test. So if you've ever wondered why that is sent in conjunction to these other antibodies, that is the reason for it. So I don't know if you guys have come across this, but there is something out there now called a point of care test. It's a finger prick test that you can run in hospitals. Some people are interested in getting it at home. I will tell you shortly why you have to be very, very cautious with performing this test at home. But this test specifically, it's called an immunochromatographic test. I'm sorry. And again, it's detecting these antibodies that I just talked about, specifically that TTG and the deaminated gliadin peptide, or DGP. If they are present, the drops that you put in contain anti-human antibodies to these. So it's called an anti-human IgA and IgG antibodies, and they will bind to the antibodies that you have that should be present in the blood drops that you put into the test. And then ultimately it'll give you a signal if it comes back positive or negative. It's a lot like a pregnancy test in that a little line will form to tell you if you are or aren't positive. And if there's no line present, then that's a signal that the test is negative. The big problem is a lot of people have studied this to look at, again, how good is the sensitivity or specificity of this test? Meaning, if you have celiac, how good is it at detecting that? If you don't have celiac, how good is it at detecting that? And the range is incredibly variable. As you can see below, the sensitivity can range anywhere from 70 to 100%. 70 is really not very good. And the specificity can also range anywhere from 85 to 100%. And again, 85 is really not the number that we're looking for. And the thought is behind this is it is a very subjective test. And what subjective means is it depends on each person that's reading the test to be able to properly look at that and get the correct answer. And because people's subjective thoughts on what they're seeing can vary a lot, that's why the sensitivity and specificity of this test also can vary a lot. So I'll show you here how it's performed. This picture is actually out of one of those studies that looked at these point of care tests at home and how good they are. So as you can see on that top left panel, that's the finger prick where you draw a little bit of blood. You put the blood into one of the panels on the test, and then you put those droplets into the other panel. And again, those are those antibody complexes that are going to bind to your antibodies if they are present. What you see down here below, and again, I'm just using this to kind of show you what this test looks like. I'm less interested or going through with you the results of this. I just wanted you to get a sense of what this test is like. So the very bottom line that says CT is the control. So you want to see that that's lighting up to know that the test you're using is even accurate and is going to run properly. And then you'll see two other lines appear, A and B. If A appears, it means you have the antibodies and the test has turned positive. The second line, like I had mentioned to you before, detects whether you just have enough total IgA in your body. Again, if that is negative and you don't have enough IgA, then this test may not be accurate as well. So what you see on this very first test is that you did have enough IgA. The second line is positive, the control is positive, but the first line is negative, which again would suggest you don't have celiac. In the second panel here, neither of the lines are lit up, which means you are IgA deficient and it's not detecting that you have celiac. But again, that may be a false negative because you don't have that IgA. The third test here is detecting that you have the antibodies and that it appears that you do have celiac disease. And then on the very last one here, you don't have the antibodies, but it's showing that it thinks you have celiac. Again, it looks for both the deaminated gliadin peptide and the TTG, so it may be that it's picking up those other antibodies. So this was the assessment as a whole, the systemic review that they did, a meta-analysis of all the studies out there that have looked at this, or as many as they could find. So again, as we know, typically celiac disease is going to be confirmed by the presence of the findings on the scope, which is villus atrophy, and I will get to that in a second, and then those antibodies. So ultimately, they found 12 articles in this review. It included 2,964 individuals, and of those, 1,265 actually had diagnosed celiac disease through the use of the blood antibodies from the standard approach and the scopes. All these tests were completed in a hospital, not at home. And ultimately, they looked at what's called the pooled. So from all the tests, the results of the sensitivity, again, that's you have the disease and the test came back positive, and the specificity, meaning you don't have the disease and the test came back negative. And so what they found as a whole, it's not terrible. Was it 94% of the time this test is going to get it right, and 94% of the time the test is going to properly reflect that you do not have the disease. So ultimately, this is a much easier test. It's a much cheaper test to perform because you do it through these little samples at home as opposed to relying on a laboratory, or not at home, but through the hospital. While the sensitivity of the test is high, it never replaces the need for a scope, because the problem is it's going to detect if you have a very low positive, which again, may be a false positive, or a truly high level that would be more suggestive of celiac disease. So this test could never replace the need for that scope. Also, like I said, it is a very subjective test. People may be looking at it and think they see the line when the line's not there, or think they don't see the line when the line is there. I may have just said the same thing twice. So if I did, you know which one I was saying. So you have to be very, very cautious with this test and know it's subjective and know it's very prone to error because of that. So at this point in time, I think the majority of gastroenterologists out there really wouldn't recommend doing this at home, just because there is a lot of leeway for error with this, but it certainly can be a very, very helpful test to use in countries where resources are short and in low supply, and in other situations such as that. All right, next up, my blood testing was abnormal. Where do I go from here? All right, so as many of you know, once your blood testing comes back normal, what we want to do is do that scope, take a look, see are there gross findings, meaning findings with the naked eye that suggest celiac disease, and then what does it look like under the microscope. So in case you're not quite sure of what those findings had shown, I did bring up two pictures up here to show you really the drastic differences that you can see on endoscopy. I will say first and foremost, I've scoped many, many patients with celiac disease. To find these gross findings, it doesn't happen a lot actually, and a lot of times the findings, especially in kids, can be very, very subtle. So we do always rely on looking under the microscope for those classic, what we call histologic findings, and I'll go through those in a second with you too. But for those patients that have those obvious gross findings, these are the differences. So on the left here is your normal small bowel. You can see you've got these nice folds in the small bowel, the villi. These are all the little villi that look like little worms here. They're little finger-like projections that help with absorption. They're nice and fluffy, and this is what a very healthy small bowel would look like. On the right-hand side is what a bowel would look like with severely active celiac disease. So you can see all those little villi are gone. It has a very flat appearance to it. This is what we call atrophy. Oftentimes, in that, what the arrow is starting to show here is you almost get a scallop-like appearance to these folds, which is starting to form here, which is very classic for celiac. And then in between the folds, you get what's called a cracked desert appearance. And I don't know if you can see this here, but it almost looks like there's little cracks in the lining here between the folds. And this is a very characteristic appearance of celiac disease on a scope when you see it. This is what it would look like under the microscope. I thought instead of giving you the actual microscope appearance, the cartoon sometimes a little easier to appreciate those findings. So again, these are like those little villi that you saw on the real-time scope. They're nice and long, intact. And as the disease gets worse, the first thing you see are what we call an increase in intraepithelial lymphocytes. These are all these little black dots that almost look like watermelon seeds here. Those are those inflammatory cells that are causing the damage to the bowel in reaction to the gluten in the diet. As that inflammation gets worse and worse, these villi start to blunt. I don't know if it's as apparent here, but they start to shorten, what we call. And then as you get farther and farther on what we call this Marsh staging, so you go from 0, which is normal, all the way over to 3, those villi become completely flat. So these used to be those nice long villi that have flattened, and you can see there's lots and lots of inflammatory cells in the lining at this point. And this is the most severe presentation that we see under the microscope when someone has celiac disease. All right, so like I said, the next couple of slides that I'm going to talk about are more the experimental things that are out there right now. You know, we're always looking for other ways to detect celiac disease. And so these are some of the testing modalities that are being evaluated. So the first one is the use of what we call MRE or CTE in the evaluation of celiac disease. So both of these tests are extensions of your standard MRI study and your CT study. What the E means is enterography, and what that entails is drinking quite a bit of contrast enterally, which means through your mouth. So it fills the bowel and gives a really, really good look at those folds of the bowel, like I demonstrated to you before on the scope, and different appearances like swelling and inflammation within the gut. And so what they found on imaging in patients with celiac disease, and the caveat here is you do have to have pretty severe celiac to find these findings, and that's the problem. If you have very mild disease, likely these tests are going to come back positive, normal, and so they may not be good indicators in those situations. But what they find in people who have more severe advanced celiac disease is that there's a change in the fold pattern. So normally those folds that I had showed you on the scope are pretty similar throughout most of the small bowel. But what they found in people with severely active celiac disease is the folds in the very last part of the small bowel, called the ileum, become increased in number, and the folds in the very first part of the small bowel, called the duodenum, become reduced or flattened. The bowel may appear dilated or more stretched out than normal and have a thicker appearance, and little lymph nodes that sit around the small bowel look like they're a bit swollen. You can also have what's called a transient intussusception, where the bowel kind of telescopes into itself, also suggestive that someone may have active celiac disease. But like I said, the problem is if the MRE or CTE is normal, that absolutely does not rule out celiac disease. If someone was to have a more mild celiac disease, things may look entirely normal. Just to give you an illustration of what this looks like, up above here, this is an MRE study. They're just showing how you can measure these folds. And then what you're seeing down below, this is the ileum. And you can see there's lots and lots of little lines here. This is very atypical. Normally, you don't see this many lines. And these are all folds that you're seeing in the ileum here. And this would be highly suggestive, again, that that person may have active celiac. And what you're seeing here, this is a small bowel. And see how flat this looks in contrast? These are the proximal small bowel folds, and how there's virtually no folds here at all, again, suggesting this patient has celiac. These are all from the same patient. This is what their scope looked like. Again, similar to what I had showed you before. It looks very flat. You're getting scalloping of the folds up here in the proximal small bowel, the duodenum. And then here, again, this is what it would look like under the microscope. All those normal villi are completely flattened and gone. Again, all showing together that this person had active celiac disease. The next slide here is just showing you what that would look like on a CT, which is similar. All right, last testing modality we're going to go into is something called a video capsule. Right now, video capsule is not approved in for the diagnosis of celiac disease. The main indications at the bottom of the slide are looking for what we call obscure GI bleeds. So someone has a small bowel bleed and we're not able to find that with standard testing, or oftentimes in kids for the diagnosis specifically of an autoimmune condition called Crohn's disease when it's isolated to the small bowel. This came out in 1998 by a man named Gabriel Eden in Israel. It was released publicly in 2001. The majority of the capsules though there are capsules that can create videos that are longer, but the majority of them create an 8-hour long video, which in total is about 60,000 images from the small bowel. People can swallow the capsule. You can see it here, roughly what the size of it is. Or if the person's not able to swallow it, we have a device that we can drop it at the time of a scope. And the study is considered complete if it gets to the large intestine, specifically called the cecum, before the study is complete. These are just pictures of what the equipment looks like. This is the video capsule that's about the size, a little bigger than the tips of your fingers. This is the belt that you wear, and that's what's called the recorder. Like I said, if the patient's not able to swallow it, we have this attachment for our scope. It's called the Advanced Capsule Introducer. It attaches to the end of the endoscope. You put the capsule in it. You advance the scope to the level of the first part of the small bowel, called the duodenum, and that's where you release the capsule to take a look at the rest of the small bowel. On the video capsule, you had seen this image before from that study I had shown, but this is that classic celiac appearance in the small bowel, again, with that scalloping of the folds and the flattening of the mucosa. So the studies have been done, and none have been done yet in children. I am very actively trying to work with our local Medtronic company that distributes video capsules to have their support and funding to actually try to look at the use of video capsules in children. So I'm in the process of that, but there are studies out there looking at the use of it in adults. This was one of the studies I came across that I thought was good to use during this presentation. It was a blinded, meaning the people looking at the video capsules and at the microscopic findings were not aware of whether this patient did or didn't have celiac. So they looked at patients with celiac as compared to those without celiac. And it was prospective, meaning that they weren't looking back at records. This was being done in a forward motion. They were all adults, and this was in the United Kingdom. They compared 20 patients with celiac disease to 23 patients who did not have celiac. They looked at those antibodies that I had talked about before. They did a scope to get those duodenal biopsies, and then they compared that to what they saw on the video capsule. So these were the findings. So what you see here was, these are all from a patient who had active celiac. So again, you get that scalloping, the flattening of the mucosa, the flattening of the mucosa here under the microscope. These were the appearance they saw on the video capsule from a patient with celiac, and that was a healthy control. So again, coming back to those terms, the sensitivity and specificity, what they found was that the sensitivity of the test was 85%. So what that means, if the patient had active celiac disease and the video capsule showed findings of celiac, no, I'm sorry, I take that back. If the patient had active celiac disease, 85% of the time, they would be able to find that when they looked at the video capsule. And the reason it's only 85% of the time is some people have very mild disease. And as I had told you much, much earlier in the talk, seeing those slam dunk findings of the scalloping of the folds and the flattening of the mucosa, we don't see that a lot of the time. And a lot of the time, the scope does look fairly normal in appearance, and it's not till we look under the microscope. So if the patient had active celiac disease, 85% of the time, they were able to properly detect that using the video capsule. But the specificity was amazing. So if the patient didn't have celiac disease, 100% of the time that scope was going to be normal. So the specificity is very, very good. The positive predictive value is the opposite. So this relies more on the test. So if the test or the video capsule showed celiac disease, 100% of the time that patient had it. But if the test didn't show celiac disease, only 89% of the time was that accurate. Because again, it's going to miss those patients that have more mild disease where the gross appearance isn't as abnormal as it would be if someone had more severely active disease. So treatment, we've just got a couple more slides here. So as we all know, the treatment is a gluten-free diet. Ideally, you really want less than 20 parts per million of gluten in your diet to know you're going to be safe. So I'm just going to go through a couple of tests. There's obviously far more than this, just to illustrate how good these tests are. So one of these tests out there, it's called Anema is one of them. These are gluten sensors. And technically, it should tell you if there's more than 20 parts per million of gluten in the sample of food that you're eating. It typically will give you some sort of indicator like a smiley face if there's less than 20 parts per million in the food. For those starter kits, it's not a cheap test. I mean, this may have gone down. I did look these up a little while ago, so the cost of this may have varied since then, but on average, it's about $100 to $300 for the starter kit. And for each additional capsule that you need, it can range from $5 to $10. Basically, you take a small amount of the food that you're eating, you put in the capsule, you put the capsule in the sensor, you wait about 3 minutes, and again, it's going to give you that smiley face if the food is safe, or it's going to tell you that the gluten is found in the sample. So there are some studies that have looked at how good it is, this test. And unfortunately, these studies showed that the NEMA sensor could be wrong more than 20% of the time. What that means is that there's more than 20 parts per million of gluten in your food, and yet the NEMA is telling you it's safe to eat. In order for the NEMA to be accurate 100% of the time, these studies showed that there had to be at least 40 parts per million or more of gluten in that food. And you can kind of think it through and understand why is that sometimes there's gluten in parts of your food and not others. So a lot of it has to do with sampling error, and then also just the NEMA's ability to properly detect that gluten. The other issue with the NEMA, again, is that if it does detect the gluten in food, it's not able to tell you how much. So was it just a teeny amount and you just happened to get that wrong part of the food? Or was this blatantly filled with gluten? And so that's another pitfall of that test. Another test that we can do to see if we've accidentally consumed gluten is a test out there. It's called a gluten detective. So this can detect gluten both in your urine or in your stool. Both have pluses and minuses. Specifically, this detects what's called a 33-mer peptide from the alpha-2-gliadin, also known as gluten immunogenic peptides. They are stable against the breakdown from the different enzymes in your body, like in the stomach, the pancreas, the intestines enzymes that they have. So you're able to detect these gluten immunogenic peptides in your blood, in your stool and your urine. There's 2 kits available. The stool kit's about $22.50 per kit, as is the urine. They each have their pluses and minuses. So the stool test, you have to collect the stool over a period of 2 to 3 days, either 48 to 72 hours, but that one will detect smaller amounts of gluten. So if you've had more than 50 milligrams of gluten in your diet, and that is typically thought to be that cutoff that's going to cause symptoms for people who have celiac disease, it will detect that and it will turn positive. The problem is you've got a 48 to 72 hour period there that you may have consumed this gluten. So it's hard to identify what that food might have been. The urine, on the flip side, all you need is 24 hours, not 24 hours worth of collection, but it will have detected gluten within the last 24 hours of consumption. But the problem with that one is you would have had to consume more than 500 milligrams. So again, the stool will detect less, but it detects it over the last 72 hours. The urine will detect over the last 24 hours, but it needs a greater volume to turn positive. So, in summary, celiac disease is a unique disease that requires both a genetic predisposition and the environmental trigger. The diagnosis includes the blood screening tests, endoscopic biopsy, and the endoscopic biopsy in the majority of the patients. And if you are concerned for ongoing gluten exposure, food items, blood, and urine testing all can be tested for the presence of gluten. Thank you.
Thank you so much, Dr. Jericho. That was so incredibly helpful. We have a couple of questions, but I also want to be thoughtful about time. So this question has come up a couple times, and I think this is important. A lot of questions this morning about the Marsh scale and about stages of celiac, and lots of questions about stage 3A. So can you just briefly, and I know this can be hard, kind of walk us through the stages of celiac, and specifically stage 3A, does this level of damage indicate how long someone's had the disease, or is it indicative of the volume of complications they have?
Yeah, no, that's an excellent question. And it would typically be directly related to the amount of symptoms somebody has. Not always, though. I mean, as an example, I have a patient that I just made a new diagnosis on within the last couple of months. And this patient, believe it or not, had 0 symptoms whatsoever, but his parent had been recently diagnosed with celiac disease. And so standardly, we will screen first-degree relatives too. And I've seen this many times now in my last almost 10 years of being here seeing celiac patients. And, you know, I tend to see this more in those first-degree relatives, also oftentimes in patients with diabetes, that they often don't have a lot of symptoms. And then this child, for example, I don't remember his exact TTG, but it was in the thousands, which is very, very high. And even though he had no symptoms, he was one of those few patients that when I scoped him, had those classic findings of the scalloping, that flat desert appearance, and then under the microscope had that Marsh 3A. So those villi that are in your gut, when they're long and healthy, they are responsible for the absorption of a lot of nutrients. They also have enzymes that help to digest lactose and the other complex carbohydrates, which is why a lot of patients, when they have celiac, have what we call temporary lactose intolerance, because they lose those enzymes when those villi get flattened. So oftentimes very early, if you have very mild disease, you may not have as many symptoms because you're still absorbing nutrients to a greater degree than you would if all those villi are flattened. So as you move through those Marsh staging, basically, those finger-like projections in your gut. The first thing is, again, you get increase in inflammatory cells. That's MARSH1. Like when we look under the microscope, we just see those increase in those inflammatory cells, but normally your villi are intact. So most of the time, those people are still absorbing nutrients fairly appropriately. But again, as that inflammation persists and all those inflammatory cells continue to cause damage, those villi keep blunting because of that inflammatory damage till they're totally gone. And when they're totally gone, again, that's what's called the MARSH3 staging. And that is when you typically don't have those enzymes available to break down the carbohydrates. A lot of people will then develop symptoms related to that, such as gas, bloating, diarrhea, and without those villi, again, you're going to have more problems with absorptions of nutrients. So those are going to be the patients that are going to have a higher likelihood of having like an iron deficiency, calcium or vitamin D deficiency, and those types of abnormalities. Again, nothing ever holds true across the board. Like I said, I had this patient recently who had his celiac serologies through the roof and had all the classic findings, and yet somehow did not have those symptoms. So while the likelihood certainly goes up, it's never 100% for everybody. So always just keeping that in mind. And with regards to, does it indicate how long you've had disease? Again, oftentimes it does, but certainly not always. I mean, I absolutely have patients that swear they just started having symptoms within the last few months and their antibodies aren't even that high. And I go in and sure enough, they have MARSH3. So while these are typical associations, nothing ever holds true 100% of the time.
I appreciate that, Dr. Jericho. Thank you so much. We have two more questions, Dr. Jericho, but what I'd like you to do is if you could go into the Q&A section, both Lisa and Judy have some questions that maybe you can type in the answer and provide some resources for them. So that would be fantastic. Thank you again, Dr. Jericho. We would clap normally if we were in a classroom setting, but thank you, thank you. We have a fantastic next speaker. We are proud and honored to have Vanessa Weisbrod with us today. Vanessa actually, after many years at Children's National, accepted a new position as the director of the Celiac Center at Boston Children's. Congratulations on the new role, Vanessa. We are honored and privileged to have you here. You've been a national face and expert in celiac disease for many years. You've been a friend of Dr. Verma, and we're thrilled that you're a friend of the University of Chicago Celiac Center. Vanessa is going to speak with us today on practical applications of the new national recommendations to support your child with celiac disease in school. So take it away, Vanessa. Thank you.
Thank you so much, Peggy, and thank you so much, Dr. Verma, for inviting me here today. I'm really excited to speak with all of you today. Just going to get my slides up here. So to quickly start out, I just want to thank a few organizations who made possible all of the work that I'm going to talk about today. First, the Celiac Disease Foundation, the Children's National Hospital Board of Visitors, the Children's National Chief Strategy Officer Fund, Dr. Shar USA, and the Osterman Family Foundation. All of these wonderful organizations supported and have helped us create these recommendations for helping kids with celiac disease at school. So we're very grateful. So I'm going to ask the moderators to please put up my poll now. So the question is, what type of accommodation plan does your child have at school? A 504 plan, an individual education plan, an individualized health plan, another type of plan, or no plan at all? Please go ahead and put in your answers. All right, so most of your children do not have a plan at all. So I'm hoping that today I will be able to help you get to a place where you'll be able to set up a plan for your child at school. So let's talk a little bit about celiac at school. We know from the talks you've heard earlier that celiac affects about 1% of people in the United States, including children, most of whom attend federal and state-supported schools every single day of the week. We also know that celiac disease can cause significant effects on our children, as well as their families, but also on the schools that they attend. So where do we find gluten at school? lots of different places. In the classroom, in early childhood, we often find gluten in the sensory tables. These are those big bins where kids are playing around with different materials. There might be pasta, there might be oats, and lots of other things that contain gluten. In art classes, when they do craft projects, things like pasta necklaces or grain collages, the infamous Play-Doh that's made from wheat starch, paper mache, which is also made using wheat flour, and you see paper mache used all the way from early childhood through high school. In science projects, some of the popular ones this year are the moldy bread experiment, where students take pieces of gluten-containing bread and rub them all over surfaces in the school. So their desks, their chairs, the keyboards of their laptops, their cell phones, the toilet seats, the handles of doors. And so you have gluten rubbed all over the surfaces in the classroom to see which areas cause mold. Just this week, I've had 2 patients that were doing a cookie nucleus project where they used cookie dough and they baked it to watch the center rise and sink. And then they ate the cookies as a reward, which contained gluten. Another one that we hear often is what makes things stretch. As we all know, in a pizza parlor, when they're stretching the dough, the gluten is what makes things stretch. So these are just a few of many examples of places where gluten comes into science classrooms. Other areas, cooking classrooms, home economics, family and consumer science classes. Obviously, the gluten can be found in the ingredients that they use in these projects, as well as contaminated on surfaces and utensils that haven't been thoroughly cleaned. There are special celebrations at school and festivals that can involve food, like on Halloween or Valentine's Day, going to the prom or homecoming dance where they would serve dinner. And we want to make sure that there's notification in advance of these events so that your child can actually participate in these things. In the cafeteria, we also know that some kids and teenagers don't always follow a strict gluten-free diet, and we know that they most often stray from their gluten-free diet when they're with their friends or peers. When they go into the cafeteria at school, they'll find gluten on the hot and cold buffet bars, things like gravy, marinades, and salad dressings, shared utensils that have been contaminated in different types of foods. There can be gluten on the tables if there was a lunch period prior to them where somebody was eating gluten-containing sandwiches or other foods, and there are crumbs or residue left on the table. And then, of course, in the actual food preparation process that happens behind the scenes with the food service workers. We also know that celiac disease can play a huge role on the social and emotional development of kids with celiac. Some students may attract negative attention from others because they're eating different types of food. Sometimes they have to ask a lot of questions in the cafeteria, or they have symptoms. They just aren't feeling well at school or have to use the bathroom a lot. On the flip side of that, we know that a lot of people with celiac disease are asymptomatic and have no visible symptoms. And so they are often judged by their friends or their teachers or coaches who doubt the validity of their diagnosis, and they probably don't take it seriously because they don't see them sick. We also know that some students experience teasing, taunting, harassment, and bullying, sometimes by their peers, their teachers, their coaches, and other adults. And when we've looked at this a little bit closer, we've actually found that the worst bullying happens from the parents of their friends. So it's not necessarily their friends that they're hanging out with all day, but it's the parents of those children who feel annoyed by having to accommodate the gluten-free diet. But what we do know is that we can prevent all of these things from happening by having an appropriate accommodation plan set up. So there are lots of federal laws that govern celiac disease and the gluten-free diet, and I'm going to talk a little bit about all 5 of these. First, laws that govern disabilities. So the Americans with Disabilities Act of 1990 defines a disability. And what it says is that a disability is a physical or mental impairment that substantially limits one or more major life activities. For a child with celiac disease, these activities are eating and digestion. Anytime a person with celiac disease puts food into their mouth, they are at risk. And this food has to be gluten-free, or there's a risk of having major bodily harm. So therefore, we know that celiac qualifies for protection under the ADA. The next law is Section 504 of the Rehabilitation Act of 1973. And this law prohibits discrimination in schools or any institution that receives financial assistance from the federal government based on a disability. So because celiac disease is covered by the Americans with Disabilities Act, it is also covered under this law. And what this act requires schools to do is to design educational programming that meets the need of the child with celiac disease. But what's really important to note is that it requires reasonable accommodations. So we cannot ask for an accommodation that would dramatically change the structure of the educational institution. So you're going to hear me say reasonable a lot today because we need to make sure that what we're asking for is reasonable. There are also lots of laws that govern food in the United States. One of those laws is the National School Lunch Act. This law provides students who qualify financially for free and reduced cost meals at school. This law also has a gluten-free option included for students who are qualified. So if the child has celiac disease, they have a disability, the school is required to accommodate their gluten-free diet, and if they get free and reduced cost meals at school, a gluten-free option is included. The Child Nutrition Act is another really important law. This act strengthened and expanded the National School Lunch Act by giving financial assistance to schools to expand equipment and offerings for breakfast and lunch services. What's also really important is that it allowed the USDA to set uniform standards for the nutrition in the food that schools serve. This is super important because a lot of schools will suggest that a gluten-free meal for a child with celiac disease could be an apple, a banana, or lettuce, because those are naturally gluten-free foods. But what this law requires is that that meal actually meets the same nutrition and caloric standards as meals served to other students. So for example, a hot meal for a hot meal. I'm going to talk a little bit more about this later, but this is something I don't want you guys to forget about. And finally, the FDA's gluten-free food labeling law. So this law regulates the term gluten-free on packaged foods. So any packaged food served to a child with celiac disease at school also has to meet this criteria. So there are several types of plans and learning environments, and you guys all voted on them to start the session. The first type, which is the one that is most appropriate for celiac disease, is the 504 plan. So this plan is a legally binding agreement between the parents or guardians and the school district. These plans address accommodations in academic areas, but they also address things in extracurriculars. So if your child is on the soccer team, or if they're on the debate team and they go to events that are off-site, the 504 plan still applies because it's a school-sponsored activity. The other thing that the 504 plan covers are things like parent-teacher organization events. So if the PTO or PTA in some schools are hosting a Halloween festival, that 504 plan still applies, and they would be required to have a safe gluten-free option for your child with celiac disease. So the 504 plan documents accommodations that will allow your child to fully participate in all educational and social activities affiliated with their school. So what's very important to note is that this plan has nothing to do with academic performance. Your child could be an A+ student or they can be a C- student, and they would have the same rights to a 504 plan as anyone else. What's confusing to some schools is that there's this other plan called an individualized education plan. And this is a type of plan that documents a disability with a child's academic performance. And we would use this type of plan for a child that has something like dyslexia, ADHD, or autism, or any other condition that affects their academic performance. So for this type of plan, you actually need a documented difficulty with achieving in the classroom, and your academic performance would play a role. Some kids with celiac disease have an existing IEP in place at the time of their celiac diagnosis. If your child already has an IEP in place, that is okay. This plan can be modified to include celiac disease accommodations. However, if your child does not have an IEP already in place, the 504 plan is the type of plan that you would want to set up. The third type of plan that public schools use is called an individualized healthcare plan. And this is the type of plan that schools are most often going to suggest for a child with celiac disease. But I want to caution you against this. The IHP deals with medical issues in the school setting. So, for example, if a child had an anaphylactic reaction to a peanut ingestion, how do we respond to a child who is sick at school? It's reactionary as opposed to proactive. The IHP is also not legally enforceable, and it typically is not a plan where you would document classroom or cafeteria accommodations. I want to focus just for a second on the legality piece of things. So I want to share a story of a situation I dealt with last year, just before COVID. We had 3 students in 6th grade who were scheduled to go on an outdoor education trip. This is where the students would spend 4 nights at a campsite learning about outdoor things. We'd had many students go through before and had never had a problem because the school district actually worked with 3 different sites. 2 of the sites had gluten-free accommodations, no problem. This 3rd site did not, and they were unwilling to accommodate any special diets except for being a vegetarian, which of course is not a suitable suggestion for celiac disease. So when we met with the site to talk to them about how they could help these 3 students with celiac disease, the accommodation that they came up with was, well, the parents can send in 4 days of frozen food and we'll keep it in the freezer for the kids to eat every day. We said, okay, maybe that's okay, but how are they going to heat it up? Well, they said, well, we don't have a microwave, so they'll just have to let it defrost and eat it cold. Well, I'm not sure how many of you on the call are sitting there rolling your eyes right now, but I can imagine that none of us would agree that eating cold, defrosted food for 4 days is a reasonable accommodation. Thankfully, all 3 of these students had a 504 plan in place. And so we were able to file a complaint, first with the school district's Conflict and Resolution Division. And because we weren't able to make much progress, we actually filed a claim with the Department of Justice saying, we don't believe this is reasonable and can you please help? Within a week, the Department of Justice issued a ruling for us saying that this was not considered reasonable, and they required the school district to provide meals from their home cafeteria delivered to the site each day for every meal for these students. I point this out because had these children not had a 504 plan in place, we would not have been able to file the complaint as we did, and we would not have ended up where we were with these kids getting 3 hot meals a day during this experience. So how do we apply all of these laws in a standardized way? So prior to 2019, there were 30 different back-to-school guides from different hospitals, advocacy groups, support groups. Dr. Verma and I agree that we all had different ones. So all of these guides had conflicting information, they had different interpretation of the laws, they were tossed around all around social media like hotcakes. Schools were getting 504 plan requests from parents that had hundreds of accommodations requests that in some cases contradicted each other. So parents were overwhelmed and schools didn't know what to do. So we realized that we had to do something. So what we did is we brought together lots of experts to develop recommendations for celiac disease. We reviewed all of the existing documents. We also reviewed literature in food allergy, asthma, and diabetes to make sure that we were doing similar things to other chronic conditions. We brought together a group of 46 experts and had 2 in-person meetings in Washington, D.C., as well as dozens of instances of feedback in online forums. To reach consensus, our expert panel voted on the recommendations and we agreed to adopt all that received greater than 85% approval. I'm happy to say that each of the ones that are in the document actually had greater than 95% approval. So who are these people who were part of it? You will recognize 2 familiar faces in Dr. Verma and Dr. Jericho, who were part of our expert group, as well as professionals from 10 pediatric hospitals with celiac centers. We had representatives from 14 national education associations, patient and physician advocacy groups, teachers and administrators from both public and private schools, parents of kids with celiac disease, students with celiac disease, a lawyer with expertise in educational law, and a gluten-free food manufacturer. The result was the 2020 voluntary recommendations for managing celiac disease in learning environments. And we developed these recommendations to be applicable in a wide range of places. We wanted them to work in public schools, private schools, charter schools, daycare centers and in-home daycares, and institutions that do and do not receive federal funding. We made sure that our recommendations were aligned with the format and detail seen in other guidelines for things like diabetes, food allergy, and asthma, because we wanted them to look familiar to schools. We wanted them to get something that they could easily use and that they were already used to using. We also made sure that the recommendations would fit into any 504 plan anywhere in the country, while still making sure that they could be useful to institutions that do not use the approach. We also made sure that we designed them in a way that people could easily put their own logo on them. So we wanted to make sure that, for example, if the University of Chicago wanted to print these out and give them out, they could easily drop their logo onto them and give them out in their centers. So how do we get to the accommodations? So you start with getting a diagnosis. You obviously need to get diagnosed with celiac disease to have an accommodation plan for celiac disease. You then have to let your child's school know that they have celiac disease, and you have to request a 504 meeting. At this meeting, which is typically called an eligibility meeting or hearing, they will determine that your child's celiac disease meets the requirements of a 504 plan. I really dislike the fact that they call this an eligibility hearing, because we know that your child qualifies. Don't be fearful of the words eligibility hearing. This is just the terms that are used in the laws that the schools have to abide by, but your child is eligible based on the fact that they have celiac disease. So during this meeting, you would assign roles, you would talk about the different types of accommodations that you want, and your school health team would start to write the plan. The plan would get reviewed by the parents, it would get signed off on, and it would get put into action. After the plan gets put into action, at a minimum, you will need to have an annual check-in to review the accommodations and revise as necessary. However, if at any time during the school year you feel as though things are not going well, or you determine new things that need to be accommodated, you can request a meeting at any time to modify the plan. So how do we select the accommodations? So I'm holding up a copy right now of what the actual handbook looks like. And at the end of the webinar today, you're going to get an email that includes a link to the full version. On pages 20 and 21 of the document is this beautiful table that has all of the recommendations that the group agreed to. They are broken down into different categories. I'm just going to make it a little bigger here. Classroom and learning and other learning environment spaces, eating spaces, and field trips, events, and other offsite activities. So there's this big table of general accommodations that are appropriate for a child with celiac disease. It's important to note that not every single one of these is going to apply to every child. So I would encourage you to look at them closely and pick the ones that your child really needs. So this is a quote from Mary Vargas, who was the lawyer who worked with us on this project. And I want to read this quote because I think it's really important. If your child attends a public school or one that receives federal funding, the institution must provide a reasonable gluten-free option that meets the same nutritional standards as offered to other children. The meal must be of equal caloric and nutritional value, or a hot meal for a hot meal. This is so important right now as the rates of food insecurity are skyrocketing. Since the start of the pandemic, we know that the rates have increased to about 27.5% of households with children. We also know that school is a main source of food for many kids with celiac disease, with some of them getting 2 meals a day plus weekend meals. There are laws that require these schools to offer gluten-free food to students with celiac during the pandemic. If you are one of these families and your school is not providing it, please reach out for help. You should be able to get gluten-free food at school, and if you're not, please let us know and we can help you. So as I mentioned before, reasonable is key. So I want to talk through some reasonable and unreasonable things. As I mentioned before, in the cafeteria, the gluten-free meal should be a hot meal for a hot meal and meet the same nutritional values. An unreasonable request would be if other students are getting ravioli, that you would get gluten-free ravioli. This is most likely not going to happen. However, you might get gluten-free pasta as an option when other students are getting ravioli. The entire school goes gluten-free. This is also not a reasonable request to make of a school. With field trips, we would want to say that the parents or guardians are engaged in planning of the field trip, that the parents might be offered to chaperone the field trip, and that if the school is providing food, that they give the child with celiac gluten-free food. Unreasonable requests would be that no gluten is allowed on any trip outside of the school, or that the school would not provide gluten-free food to the child with celiac disease. So now these are a few examples of things that families have come to us with that were unreasonable and how we helped them. My child is a picky eater and wants the cafeteria to select gluten-free options that their child likes. So they have to provide a safe gluten-free meal, but they don't have to provide specific foods that the child prefers. So in this situation, we would recommend having a calm conversation with the food service manager to look at options that might work. What some families don't know is that school cafeterias have gigantic ordering lists. They have these huge books where they can pick things that fit into different price categories. What I would recommend is if your child really doesn't like the gluten-free options that are available, is asking to meet with the food service manager to look through those ordering books to see what is possible. I've never had a situation where we were not able to find something that worked. I don't want any gluten in a classroom where my child is learning. So we are not able to ask for a dedicated gluten-free classroom. What we can do is require the school to have a safe space for your child to learn. My child gets hungry early, so I want them assigned an early lunchtime. So as I think all of the doctors on this webinar will agree, celiac is triggered by eating gluten, not by the time of day in which the child eats. So if this is a problem, we would want to talk about how we can have your child have a more substantial breakfast or find a time for a safe snack. Bottom line, please be reasonable. Don't stretch the limits outside the scope of celiac disease. So I'm going to play a short video now to show how some schools are accommodating celiac disease.
I go to public school in Virginia, and all my friends get a nice, warm, and safe lunch. But I'm stuck with a lunchbox. But now they can provide me a nice and safe lunch.
When Rowan was first diagnosed with celiac disease, the cafeteria at her school did not provide any gluten-free options. Working within the 504 process, we were able to work with the dietitian and the cafeteria staff to identify items that Rowan could have that were safe. And she's now able to eat gluten-free pizza on Pizza Friday with all of her classmates. I'm really excited that she has the opportunity to be included and to have the same thing as her friends.
One way that my school accommodates my gluten-free diet that makes me feel safe and included is at class parties. During class parties, everyone eats gluten-free food so that no one feels left out or different, and I don't have to worry about cross-contamination. I love my school. My school has a no food policy, so I don't need to worry about gluten in my classroom. When my friends bring in a snack for their birthday, I usually get something different because it's usually not gluten-free. So when I get something different, it's usually twice the size. What I love about my Taco Tuesday is that I get to have my favorite food, tacos. And they did it a different way at first, but then I got used to it and I tried it and it was yummy and delicious.
The dietitians at Rowan's school have been working really hard to identify additional options for her in the cafeteria. They're just like her classmates who are also eating Taco Tuesday. It turns out a lot of the options that the kids are getting can be made naturally gluten-free without a lot of accommodations. And so she's able to participate and have some of the very same meals that the other kids are having. We've just had a great experience using the 504 process to ensure that the dietitian and the school cafeteria staff, everybody's on board to ensure that she is able to eat safely.
So what do you do next? Within this document that you're going to get a link to, there are lots of action lists, and these lists are really important. They have step-by-step guides for what parents and guardians, teachers, school nurses, physicians, kids should be doing to make sure that things are going smoothly at school. So definitely check out these pages, share them with your child's school, read them carefully yourself. I also really love the action list for kids. They don't just help them at school, but they're really age-appropriate lists for what your child should understand about their disease at a given point in time. So we have them broken down for young children, 3 to 6, ages 7 to 12, and teenagers. So please take a look at those. So the parent guardian to-do list, I'm just going to really quickly go through this because you'll be able to see it in the handbook. But as I mentioned before, you're going to get a diagnosis letter and send it to your child's school. You're going to read a copy of this handbook. You're going to read the sample 504 document, which is going to come to you along with the copy of the handbook. You're going to share these documents with your child's school, and you're going to attend these meetings, provide feedback, and sign off on the plan. If there's one huge thing you take away from today, I hope it's that you will include your child in these discussions. We want your child to be a part of their accommodation planning because we want to make sure that what they're using at school is what they actually want. So for example, do they want to eat lunch at school or do they want to bring lunch from home, or do they want to eat the food from the school cafeteria? Is there someone at school that they feel more comfortable approaching if they're feeling sick or having a problem? What materials are they actually using in class? You won't believe the number of times that I have meetings with families and the parents think they're not using gluten at school, and the child turns around and says, "Mom, we use gluten-free, we use gluten-containing stuff all the time," and the child lists all these things that the parents aren't actually aware of. Do they bite their nails or put their hands in their mouth? This is really important as we're planning for making sure they have access to hand washing. If you don't include your child in the discussions, we're really worried that they won't use the accommodations that are listed because they don't know about them. They won't know how to access certain tools that are available to them. And finally, they probably won't appreciate all of the hard work that went into them if they're not involved in the discussions. So I want to show you quickly a sample plan. So this is, you're all going to get a template along with the handbook that is a drag and drop, so you can insert your child's information into these templates. So the basic plan has their demographic information, the purpose of the plan, an explanation of the diagnosis, and the treatment of the gluten-free diet. Then you have this table where you can easily drag and drop the recommendations that we've talked about. So there's the classroom and learning spaces, eating spaces, and field trips and other offsite activities. It's a Word document, so you can very easily modify it. And finally, the plan for a gluten exposure. So this is where you would put how to handle what if your child is sick at school, and you want to be really specific here so that the school knows exactly what to do for them if they aren't feeling well. So since these recommendations were finished last year, we have already used them in 33 states that we know about and have successfully built 504 plans using this document. And I hope that by this time next year, the entire country is colored in as having used them. So where do we go from here? Right now, we're conducting lots of trainings around the country, not only for patient groups, but also for physicians. We've partnered with Open Pediatrics and the Celiac Disease Foundation for all of these trainings, and we're working with national associations to get to the educators. So this is just a snapshot of this Celiac Disease Foundation site. So at school.celiac.org, we have one training program for educators and caregivers, one for food service providers, and one for parents and guardians of children with celiac disease. So if you have time, I would definitely recommend checking that out. On Open Pediatrics, we have continuing education programs for physicians, nurses, social workers, and psychologists. And the goal here is to make sure that at the point of diagnosis, this information is being shared with families. It's also important because all of these laws are not just applicable to celiac disease, but also to other conditions that providers work with. The training programs include a series of 10 videos that are adorable. These are just a few of the faces that you'll see in the videos. You see again here, Dr. Verma and Dr. Jericho. We had planned to film all of these videos in March and April 2020, but as you can imagine, with COVID, we were not able to do that. We had 4 days of filming planned in schools and cafeterias, but we couldn't do that. So everybody came together and filmed the video series from home. And I can't share how thankful I am enough to everybody who participated in this project. I'm going to leave you with a thank you. So it's a lot of work to put these plans together, and I know that it isn't easy for any parent. I have a 7-year-old with celiac, and I've been through it myself. But I just want to remind you to say thank you to your child's school when they do something well. So here's a few examples of some kids saying thank you.
Thank you for always making sure I had gluten-free options and sometimes giving everyone gluten-free food so I don't feel different. Those are the best tacos ever! Thank you, Chef Amanda, for making sure that if something wasn't gluten-free for lunch, that I could eat something else. Thank you for the cookies. They're so good. And thanks so much for the gluten-free Play-Doh. You made me feel really safe. Thank you for letting me store my gluten-free snacks in the closet when I couldn't eat the pretzels. Thank you for supporting kids with celiac disease. Thank you for supporting kids with celiac disease.
So thank you so much to everyone for listening today, and I'm happy to answer any questions you might have.
Vanessa, thank you so much. That was fantastic. So helpful to so many of us as parents, as healthcare providers. It's great to see all the advocacy work that you've done. I know that we have a couple of questions, but I also want to do a time check. So we have a break right now. And the beauty of the break is that we can spend some time just chatting and answering a few questions. Dr. Verma, I would love for you to get on the discussion if you can. And we also, certainly can answer questions specifically regarding what Vanessa just reviewed. We had some good questions in the chat. So Vanessa, why don't you talk just a little bit about how people develop 504 plans or not with their high school or college? Lots of questions about that. When a child is able to advocate for themselves, it sometimes becomes confusing for parents to figure out, do I really need a 504 plan in high school? Do I need one in college? Although I have to tell you, we've received many questions from families who are struggling with the college that their child is attending. And most colleges, even private, do receive some federal funding. So that's interesting. So talk to us a little bit about that, if you don't mind. And Dr. Verma, I'd love for you to jump in as well, because we did have some questions regarding follow-up, although I'm going to try to borrow some time later. So Vanessa, go ahead. Tell us about high school and college.
So you definitely want a 504 plan in high school for a few reasons. So obviously a child in high school is able to advocate for themselves and take care of themselves in a different way than a child in elementary school would be able to. They need less help with asking questions and ensuring that things are, gluten-free. However, there are a lot of things in high school that happen off-site and away from home. So in high school, we think about things like prom and homecoming dances, where the kids are eating off-site at a hotel or at some event space. And we don't want the child with celiac disease going there and being told, oh, there's nothing you can eat here. We want to plan in advance so that they can eat the same meal alongside their friends. We also don't want them getting sick at the prom. I mean, imagine being all dressed up and your hair all done and looking beautiful, and then you eat something with gluten in it and spending half the night of your senior prom in the bathroom being sick. So that's just one example of planning ahead for it. When going to college, so college is an interesting situation. If you go to a public university or one that receives federal funding, like Peggy mentioned, the 504 plan applies. So if you have a 504 plan that was set up when you were in kindergarten or middle school or high school, you can transfer that 504 plan to the public university or one that receives federal funding. Obviously, the accommodations are going to look different in college than they would in a lower school setting. But again, in college, you're eating in the cafeteria. You want to make sure that there's food available to you. When I was diagnosed with celiac when I was a senior in college, and my school came to me and said, the dietitian said, we have white rice and coffee. And those are the only things we can verify as gluten-free. And of course, my parents had just spent like $6,000 on a meal plan, and like, she's getting white rice and coffee. That sounds horrendous. And it took a huge amount of advocacy to get them to refund the money so that I wasn't, stuck eating those two things. I think they eventually added like a Jamba Juice smoothie to the dining hall that I could have. But so, it would have, this was, almost 17 years ago. So things were a little bit different back then, but today we would never stand for that. The school would have to accommodate, and they should have a 504 plan.
I think that makes sense. Dr. Verma, would you like to share a little bit more about your experience with high schools, colleges, and also follow up. I mean, one of the questions we're going to talk about a little bit is this is a question I would have as a parent. So I have a child with food allergies personally, but she doesn't have celiac. But I think you brought up such a valid point, Vanessa, about all the gluten products that kids have their hands in all day. What I don't understand as a parent or even as a nurse is what the level of exposure is, how you can measure it, and how you know if it's going to cause your child complications, even if they're not having symptoms. If they have their hands in Play-Doh, like what if it's affecting their villi, and how do you assess that? That's a really important question. Dr. Verma?
I think that, there are two things that I would say. One is the follow-up is important. So when you're seeing anyone with any chronic illness, again, we talk about celiac disease, and sometimes it's us as medical providers that sometimes maybe underplay the disease. But if you have any chronic disease, you have asthma, you have diabetes, you have Crohn's disease, you have whatever, you're going to be following up with your doctors. And part of it is the reason you follow up sometimes, even with acid reflux, you follow up because you need a prescription. So you have to think about celiac disease in that mindset. It's a chronic disease. It's not just a matter of staying away from a gluten-free diet. So even if you're 100% gluten-free and you're fanatic about it, which you shouldn't be, but if you are, you still need follow-up because the diet itself is not that, healthy all the time. So you need to follow up with dietitians. You need to have follow-up blood work and things like that done. So that's one. And then if you have a child who has their hands everywhere, or their hair in their mouth, or those kind of things, then again, that is another reason that you want to follow up for blood work. You want to follow up, not just blood work then, because anyone can do a blood work, but it's a discussion. It's for the child to understand, as Vanessa said, everyone needs to understand why you're doing this. So if that child can understand why they have to stay gluten-free, you probably get a little bit better buy-in from them. So that's one of the reasons I think that it's important to follow up. It's important to know what you're doing. But at the same time, we do not want parents or children to become hyper-vigilant. It really turns the tide over, and the children actually don't do well if we are this hyper-vigilant on things. So that balance, and that again comes up as part of follow-up when you meet your team to have that discussion, share the burden with your team.
I so appreciate that. And Dr. Verma and I have discussed this many times. Vanessa, you would agree that once folks get their biopsy or get their lab results and they go on a gluten-free diet, we often don't see them again, particularly for teenagers and young adults. We want to see them again. So at Boston Children's, I'm sure you have a program at the University of Chicago. We're creating a transition program specifically to work with teenagers directly and remind them about what the needs are, what's important, and also really talk specifics. So, for young women, like in girls, do you want to buy gluten-free makeup? What are the pros and cons of that? What are the pros and cons of other beauty products at home that are gluten-free? So we need to have these discussions. And also, if you've had exposures, let's like be totally honest and open about it. And then we are totally cool with it, no matter what the exposures are. But then let's understand what that means for you, right? Did you have symptoms? Should we do more blood work? What can we do to kind of tweak your diet or help you tweak your life a little bit? So I so appreciate that. And I would love, Vanessa or Dr. Verma, if you could in the chat, provide any resources just in terms of links, if you could, regarding these sort of non-food resource websites that maybe provide information about gluten-free products. Vanessa, is that something maybe you could provide?
Yeah. Absolutely. And I would just want to say that especially in high school and college, any peer-to-peer support that your kids can come across. I'm sure Chicago has this. In Boston, we have a really active teen support group where sometimes just getting, like the parents out of the room and allowing the, really experienced kids to have time with the newer diagnosed kids. And even, just to have a friend who's going through the same thing as you to talk about, I think can be really important.
Great, thank you.
We do have an in-transit program, so it's a program that we're actually starting earlier, because I think if you're already in teen and transitioning, you're a little late. So we have an in-transit program where we are actually meeting, and we want the children to be engaged in that.
Absolutely, where we're talking to the patients directly, not to mom and dad, not to the caregivers, and encouraging, folks even at age, 12, 13, 14, 15 to start advocating for themselves, understanding who to ask questions of, how to ask those questions, feeling like they can articulate and be advocates for themselves. We do have a time check now of 10:30. This was great because now we can provide more information about the in-transit program. I'm going to do that right now on the chat. And then also, you should rejoin us by clicking on session 2. So in your join the session, it should say session 2, and session 2 begins at 10:40. So just in about 9 minutes. So run to the ladies' room or the men's room, grab a cup of coffee, grab a spouse, a kid, a stuffed animal, whatever you need. And we'll be back in 9 minutes, guys. So thanks again for everyone and for their help. And we'll see you for session 2. Talk soon.
Thank you.
Thanks.